So it's an incredible honor for me to introduce Dr. Vivian Lee. I want you to know that at least 28 people in this room would like to be introducing Dr. Lee because she's an incredible woman. Since July of 2011, Dr. Vivian Lee has served as the Senior Vice President for Health Sciences, Dean of the University School of Medicine, and CEO of the University of Utah Healthcare. She's responsible for an annual budget of $3.3 billion, including a healthcare system, health plan, schools of medicine, nursing, pharmacy, health, and a new school of dentistry. A graduate of Harvard-Radcliffe, Dr. Lee received a doctorate in medical engineering at Oxford University as a Rhodes Scholar. Returning to Harvard, she earned her MD with honors. Following a residency in diagnostic radiology at Duke, she trained as a fellow in MRI at NYU and also completed an MBA at the Stern School of Business at NYU in 2006. An NIH-funded investigator for nearly 20 years, Dr. Lee was elected to the National Academy of Medicine, formerly the Institute of Medicine, and the American Society of Clinical Investigation. She serves on the NIH Council of Councils and on the board of 2 publicly traded companies, a fellow and past president of the International Society for Magnetic Resonance in Medicine. I'm not even going to try to pronounce that acronym. Dr. Lee has authored over 160 papers and a popular textbook, Cardiovascular MRI, Physical Principles to Practical Protocols. Dr. Lee's address this morning, the 2017 Malcolm L. Peterson Honor Lecture, is Empowerment and Resiliency, Engaging Physicians in the Transformation of Healthcare. Please join me in welcoming Dr. Vivian Lee.
Thank you. Thank you so much for that very, very kind introduction. I'm really, really delighted to be here this morning. And I want to say, as a humble MR radiologist, recognizing that the future is not looking super bright for our field, I am full of admiration for all of you in this room. And now I get a sense, having come here, why this is everyone's favorite meeting. There's so much energy and there's so much buzz, and I'm just so honored to be delivering this Peterson lecture and to be a part of it today. So thank you very, very much. And as I start, I just want to give a shout out to some of the remarkable general internal medicine leaders that we have at the University of Utah. They didn't know that I was going to put this in the slide, but I am just delighted to brag about our leaders in general internal medicine. Molly Conroy just joined us 6 weeks ago, who is the division chief and also professor in population health. Rachel Hess, who actually helped us get going in this whole field, is the chief of Health Systems Innovation and Research in Population Health, as well as the director of our CTSA, and a very proud faculty member in general internal medicine. And Carolyn Milne, who has a leadership role in the internal medicine department overseeing our residency program, and is also a very proud general internal medicine leader. And they are all led by our chair of internal medicine, Kathy Cooney. I just don't want you to have the impression that we only have women leaders at the University of Utah, so I will share with you I'll share with you some of the outstanding work that is being done by men and women in general internal medicine and across our health system very shortly. Now, I know many of you, in hearing the word Utah, are probing deep into the recesses of your memories of 5th grade geography and have this question, just which one of those states was Utah? So just to remind you, this is the perspective that I had about 6 years ago coming from NYU. 9th Avenue perspective, I was more on the 1st Avenue side of it, but generally you get the idea that Utah is somewhere between the Hudson River and the Pacific Ocean. And actually, if you get to know us well, you'll recognize, if you look at this poster up close, that actually they even got a mistake. They have us south of Las Vegas. We're actually north of Las Vegas. But that's just a little detail. And in terms of who we are a very unique academic medical center. So here is the map, and Utah is the state that has a little bite taken out of it. We are the only academic medical system in the entire region, so covering the states of Utah, Idaho, Wyoming, Montana, western Colorado, and much of Nevada. We serve about 10% of the continental U.S., And we're probably about an average-sized academic medical system with 4 hospitals, 12 community clinics, a number of regional partners across the entire geography, 1,400 physicians, and we do have our own health insurance plan with about 160,000 members. We have a rich legacy of research, particularly in genetics, genetic discovery. The BRCA1, BRCA1 gene, for example, was sequenced at the University of Utah. APC, P16, a number of disease-causing genes. And we are an integrated health system, which is also very important for us, including the School of Medicine, Nursing, Pharmacy, Health, and a brand new School of Dentistry. Now, the message in the story that I want to talk today is building around value and the critical role of our physician leaders in that transition and transformation, and the importance of resiliency of those physician leaders. And so I'm just going to start by talking specifically about our work in value. And in Utah, I think we are fortunate to be able to start from a very strong position. So this is one of the favorite slides that I like to show. What you see on this slide is 50 circles, and each of the 50 circles is are the 50 states. And on the y-axis, it's the affordability. It's the healthcare costs per capita. And you'll see that at the very top, this is why I like to show this slide, Utah is the lowest in healthcare expenditures per capita. And of course, every time I arrive at Logan Airport, I pull this out and immediately start sharing it with my friends, Boston, just joking. And then on the x-axis, it's the affordability, it's the healthiness of the population on the x-axis, and Utah is consistently around number 6 or 7 in the country. So when we try to talk about what this transformation to value means to the community and to the population, we try to say it in these terms. What we want to achieve is the healthiest population at the lowest possible cost. When we talk about this internally, this is one of our favorite slides where we define value. It's not really a mathematical equation, but it's a good way of expressing what we're trying to achieve. So we want to have great quality, particularly patient outcomes. We want to deliver it in a very patient-centered way. We're very concerned about patient experience, patient satisfaction, particularly with respect to the provider-patient relationship. And then we want to be able to deliver those at a reasonable cost. And so now I have one slide or two essentially on each of these to share with you where we are at the University of Utah. And I will just put in a little disclaimer at the beginning to say that my title is CEO, but it could just as well be CBO, Chief Bragging Officer. So just bear with me for these next few slides. It's sort of part of my responsibility. So on quality, we are very proud that among all the university health systems in the country, part of the UHC consortium that shares all of our quality and safety data, it's now called Resilient, the University of Utah was ranked number 1 in quality this year. And we're an excellent company, my former institution, NYU, and with the Mayo Clinic. And probably even more proud, what we're really more proud about is specifically what those metrics reflect. It's completely data-driven, and it's around quality, access, equity, communication, patient experience, and efficiency. And for the last 7 years in a row, the University of Utah has actually been in the top 10. I particularly note the number 1 ranking in 2010 because that was the year I was being recruited to Utah, and it was a very, very important piece of data for us. And the tremendous improvement starting from 2008, from where we were about the middle of the pack, and moved to number 1 in 2 years. And that, for me, was a real sign of an organization's ability to respond to change. That preceded my arrival, but really influenced my thinking about the University of Utah. With respect to the patient satisfaction or patient experience, here's a summary of the work or the metrics, really, for patient satisfaction at the University of Utah. And what I'm showing you here are 2 curves. The red curve is the percentage of our providers who are in the top 1 percentile, so the 99th percentile or above in patient satisfaction. And in gray is the percentage of our providers who are in the top 10 percentile in patient satisfaction nationally. So you'll see that around 2009-10, we were what you might expect, about 1% in the top 1 percentile, about 10% in the top 10 percentile. And then over the last several years, we've seen significant improvement in patient satisfaction. When I arrived around 2011 and 12, we were already exceeding expectations, about 17% of our providers were in the top 1 percentile. Many of you will know that in the end of 2012, we became the first system in the country to post all of our patient satisfaction scores and responses and reviews online. So for all of our providers who have had at least 30 responses from patients on their physician website, so this is Dr. Gia Lewis, one of our burn surgeons, you will see the actual raw score of what patients reviewed her. She received a 4.9 out of 5 in this last period of time. The individual answers to each of the questions that we ask, and I want to call out that those questions are really about the patient-physician experience. They're about clarity of language, engagement in decision-making, about really patient-physician relationships. They're not about the food. They're not about things that are outside of the physician's control. I just want to call that out. There is one question about wait time. And then we post all of the patient satisfaction, all of the comments, and we do not filter those comments at all. And it was really that, I think, that led to this last significant increase, which has been sustained for the last 4 years or so in terms of our overall patient satisfaction. 40 to 50% of our physicians in the top 10 percentile and a quarter of our physicians in the top 1 percentile, despite significant recruitments over the last several years. And then finally, what I'll talk about a little bit more shortly is our work in the cost domain, really measuring costs, providing that feedback back to physicians, and seeing the improvement and reductions in costs together with improvements in quality. So the message that we're trying to share is that the future of healthcare is not as dim as everybody seems to want to make it out to be, that we can engage on a virtuous cycle of value whereby committing ourselves to the patient-physician relationship and patient satisfaction, patient experience. We create a more patient-centered culture that drives quality, and as quality goes up, we have fewer complications, fewer readmissions, shorter lengths of stay, and costs can come down. And that is the virtuous cycle that I think not only we at the University of Utah need to engage upon, but the entire nation needs to engage on. And what's critical to our success, in my view, is the physician leadership that we have. And I've already shared with you the photos, and you know some of our physician leaders, and I'll continue with that messaging in terms of just how critical the physician-led component of this is. And that physician leadership, of course, is completely predicated on physicians being well and the resiliency piece. So the idea of physician-led measurement of quality or measurement of outcomes has a long history. I don't know how many of you recognize this individual. Anybody recognize who this is? So this is an orthopedic surgeon, Ernest Codman. Around the turn of the century, he trained at Harvard. He was at the Mass General. He was on staff there. And he was an advocate, a very ardent advocate of the notion that he called the end result. And that was the idea that all physicians should know how they're performing, that all physicians should have feedback on the end result of their patients, how their patients were doing in terms of outcomes. He was essentially the first person to create the dashboard or the scorecard at the individual physician level. Just as a side note, for that idea and for trying to push that concept forward at the Mass General, he was fired. Just saying. So he's a little bit ahead of his time. But he went off and set up his own hospital, which he called the End Result Hospital, actually, interestingly. And so he proceeded anyway, despite that little bit of a setback. And this notion of trying to give feedback back to physicians and having physicians define the metrics that we should be being measured by has sort of percolated along, not with tremendous success, I would say, over the last century. And when I joined the University of Utah, one of the things that I was faced with is this notion of value transformation. And remember, I'm an MRI radiologist. I'm not even close to really understanding healthcare. And so when people said to me, you know, Vivian, we've got to decide about bundled payments and what are we doing in value, I said, where's our value tool? Where's our tool that tells us how we're doing in terms of quality against costs? And not even necessarily what we're charging, but what it actually costs us to provide care, which is what the value equation would be internally in our own operations. And I was a little disconsolate to be told, well, we have a ton of quality metrics. I'm not sure how many of them really correlate with outcomes, but we have a ton of them. But we don't have any real measures of costs at the individual physician level. And I thought, oh my goodness, I've landed in Utah and they don't even know their cost. What have I gotten myself into? And then I started reading a little bit in the literature on this, and this was some work by Mike Porter and Bob Kaplan. And they've written several papers, and this is one of my favorite quotes from a paper that came out in the Harvard Business Review in September of 2011. For a field in which high cost is an overarching problem, the absence of accurate cost information in healthcare is nothing short of astounding. If costs are such a problem, the fact that you don't know your cost, well, that might be the problem. So when I read that, I thought, well, at least it's not just us in Utah. But we realized that in another editorial that they wrote that was published in the New York Times, the real issue is not only do we not know what it costs to deliver health care to individual patients, we also don't really know how those costs compare to outcomes achieved. Understanding cost could be the single most powerful lever to transform the value of health care. So we were all thinking about it about the same time. I think people across the country were thinking about the same time. And what we tried to do was to work together across the institution to try to create that tool, to try to be able to measure our outcomes for each patient against the actual costs of care. And so I just have a few slides to take you through over just a big picture level of how we did that. The team included people from finances, from IT, from departmental administrators, bioinformatics, many, many physician leaders, mostly coming from general internal medicine and our hospitalist group. So we set out to understand our costs, looked at supplies, looked at pharmacy. Those were very easy. What was more complicated was time in facilities, like how much did it cost for every minute in the operating room, every minute in the ER, every minute in the MRI scanner, what did it cost for labor, how do we break down physician time? So you might be doing some research, you might be doing some education, but then you're also doing clinical care. How do we account for your time with Mrs. Jones and her pneumonia, for example, as opposed to Mr. Smith doing the hip replacement? And then once we put it all together, we put it in these cost group typings that we could kind of relate to. As I mentioned, supplies, pharmacy, also imaging, facility utilization. And here's an example of the kind of component costs for any particular episode of care for any patient in our system that we did. So this is just one example. We've now costed out every patient in every episode across our entire system. But say a patient came in with appendicitis, and a more complicated patient with more comorbidities, just to make it a little bit more interesting, comes into the ER, goes to the OR, goes to the surgical ICU, into the step down, and then back to the floor. So in order to figure out the cost, just in the emergency department, there are cost of labor, supplies, imaging, pharmacy, lab, other services. Operating room, again, costs various components, particularly labor and supplies. The surgical ICU, the floor, and then when you add that all up, we have a total cost of care for providing, for taking out that appendix for that particular patient. And then the way in which we can slice and dice that data is really amazingly flexible and really fascinating. So here's just one example. This was actually one of the very first pieces of data we got out of this program. But this is an example of what we can do. So here are the 10 orthopedic surgeons who have done DRG 470, so that's major joint replacement of the lower extremities. That's total hips, knees, and ankles. And the average cost, so again, I just want to emphasize again, this is not charges. This is what it actually cost us to provide this care. Do you understand what I mean? It's the actual cost of running our business. So for these 10 surgeons, you can see that there's quite a lot of variability in the overall costs. These are average costs over 2 years. A couple of the big outliers can be explained by the fact that one of them takes care of our sarcoma patients and the other one does ankles. So that's why they're a little bit more. But the rest of them tend to do what I refer to, it's easy for me to say, bread and butter, hips and knees. I'm the radiologist, so what do I know? So here you have, and you see the different colors, and the different color components are the different supplies, radiology, pharmacy. And just even from the back of the room, without being able to see much of anything, you can see that there is quite a lot of variability. And in fact, when we started looking at this, it's a web-based tool, so I can, you know, at home, I can sort of click down and look in every possible group that I'm interested in looking at. What we observed was the only constant is the variability. The only constant is the variability. So once you start showing these data, you know, for me or for any of you in the room, I ask you, how many of you have ever seen this data for your own patients? How many of you know how much? Okay, so I see 3 hands, 4 hands, and then there's our table, of course. So this kind of data given to physicians is incredibly interesting. Well, first of all, of course, we will always challenge the data. You don't always have the data right. So we can do a couple of iterations of improving and cleaning up the data. There's no question that we always have to do that. But once we do that, the data are incredibly enlightening. Why is Dr. J using this device as opposed to Dr. D doing that device? Why are you using that DVT prophylaxis approach as opposed to this? Why are you, a lot of discussion. And what it leads to is a very important need for some new skills that we don't really have as physicians. At least many of us don't. Many of you may have it in having gone for extra degrees or extra training. But what we don't really have, most people like radiologists certainly don't have the experiences understanding how to do process improvement and process mapping and really understanding why there's so much variability. And so around the same time that we started the video tool building, we also rolled out a system-wide training program for Lean in partnership with our business school. We charged groups with coming up with interesting questions that they wanted to solve, problems that were giving them headaches, like why does the operating room always start late? Turnaround time for a colonoscopy, wait times in clinics, running too long. And so they put together teams and really worked on the PDSA, Lean, process improvement. And consistently we saw, or consistently so far in our pilot projects, we have seen some interesting changes once you start giving the data back to physicians. And this is a complicated slide, but I'll just take you through it. If you focus on, there are a couple of, let's see, I don't really have a pointer, so I'm just going to say, look at the blue lines. Okay, the blue lines are the quality metrics. So first of all, we asked the physicians to come up with an overall summary quality metric. This was the orthopedic surgeons looking at total joints. So they're complaining about all the different quality metrics that are being imposed upon them. So we said, okay, let's take some of those. We still have to measure them because we still need to get paid, frankly. But you add on to those some metrics that you think are important, like one of them was getting up and out of bed the day of surgery. And we'll synthesize those all into a blended, weighted metric, which we call the Perfect Care Index. So the blue line is the measure of the Perfect Care Index. The first one is the dark blue. The dotted lines are before the intervention. The solid lines are after the intervention. We started with the blue line measure of perfect care. And as that perfect care index was getting better, some of the components were getting hit 100% of the time. They said, okay, we need to continuously improve. So they moved to the light blue line. So they raised the bar in terms of what perfect care meant. Does that make sense what I'm saying? And so the feedback was given back to them. We're sort of tracking that perfect care in the light blue now, and we hope once, oh, I'm sorry, I got it backwards. Light blue was the original measure. I'm sorry, I got it backwards. Light blue was the original measure, and as we were hitting 100% on many of those components, we made it into the dark blue measure. So of course we went down in terms of the perfect care index, and as that continues to move up, we hope that we can then raise the bar again. Does that make sense now? And then while we're doing that, in red, it's our overall cost of care. So we saw about a 10% decrease in the cost of care in the first year of implementation. So this has been a big team effort, and just a shout out to the entire team that contributed to one of the publications in this work. The original work on video is in JAMIA by Ken Kawamoto. And this is the Ken Kawamoto who's shown here sitting in the seat. And this is the article that came out in JAMA last year, and some of the fantastic contributors there. And I just want to shout out, in terms of the importance of general internal medicine and our team, the very strong showing of GIM in this work, and how grateful I am to everybody's hard work here. So that is a big part of the data that is driving our work towards value transformation, because you can imagine not only with measures of quality and cost, but also integrating patient satisfaction. And I'll talk at the end of some of the more the newer things that we're adding to it. Now, from my perspective, the most important component of success, and we've seen others now start to try to do the data and try to create the same tools, and we're helping people when we can. But that's not so much the story here. It's not really so much about this tool. It's really about our leadership, and it's about particularly, I want to say, our physician leaders and then the teams that they lead. So I want to spend a moment talking a little bit about my observations on how to motivate leaders, and where I think there's a little bit of a disconnect between how we as a nation are thinking about the transformation and the motivation and the carrots and sticks that are being used to try to incentivize us as physicians, as opposed to, I think, what I've seen really work at the University of Utah. And the reference that I use is Drive, that book by Daniel Pink. How many of you have read this book? Very popular book. And if you haven't read it, it's not only useful for physician leaders, it's really useful for teenagers. If you're managing teenagers, some of you might be, like me. Okay, so there are three components, as you know, to thinking about how we tap into the internal motivation and the internal drive. And that's what this book, for me and physicians, really is about. It's about tapping into the internal, the intrinsic motivation of our physicians. Because once you tap into that, we're unstoppable. So there are three components that he talks about that I think are really relevant. The first is we all have to have a strong sense of purpose. I think in healthcare, among all of you in the room, there's no question. We are here, we are committed to making our patients better. We are completely committed to that. And in addition, I think especially in the newer generation of physicians that I see in our medical school, all of our students and our residents, they are also very motivated in terms of having an intrinsic sense of purpose about not only caring for their patients, but also helping to fix healthcare. I think this is kind of a check. This is not so difficult. This is the one that's the most challenging. It's autonomy. And physicians really have to have a sense of autonomy. We have to be able to define how it is that we want to interact with our patients. We don't want to be told by others how to care for patients, and we don't really want to be told by others necessarily how we should be improving the healthcare system. And here's where there is, I think, a fundamental disconnect. We are very intrinsically motivated. We didn't need people to tell us that we had to get an A in organic chemistry, because we kind of knew we had to do that just to get into medical school. We have a lot of drive is based on that autonomy, and that's where there's a lot of challenges and leading to a lot of the burnout that we'll talk about. And then finally, there's a sense of mastery. And I think what's interesting about physicians is not only do we like to master things, we like to outmaster other people. So sometimes sharing these data, especially making the data more and more transparent, really taps into a lot of motivation in physicians, especially if they think the data and the measures are fair, to outperform. Nobody wants to be average. So tapping into that intrinsic motivation, I think, is very, very important. And most critically, as I mentioned, is, I think, right now, the autonomy piece in terms of thinking about how do we create resilient leaders. And all of physicians in the hospital are leaders of some sort or another. So that resiliency is critical to our success. And all of you know about the concept of the additional aim to the addition to the triple aim in terms of clinician, staff, wellness, and satisfaction. And I don't need to, I'm sure, share the data with you. You all are very well versed in this issue, the crisis of burnout rates nationally among all physicians, among residents, depending on which papers you look at, 50 to 75%, and among all physicians, around 55%, but every time I look at a new paper, the number is higher and higher. I actually recently just looked at this for radiologists, and radiologists are among the highest in burnout across the country, around 65% now. And in some groups like orthopedic, musculoskeletal radiologists, the latest paper showed the burnout rate was about 80%. About 80%. So I feel this very much in my own area of specialty. In terms of our data at the University of Utah, we have numbers that look something like this. In the last survey, about 46% of our residents, the fellows, seem to be in a better place, 23%, and for our physicians, about 30%. So while we're pleased that we're lower than the national average, 30% is a big number. And so it's something that is very, very important to us in our system. And you know that burnout, that takes away from everything we're talking about in transformation and in healthcare and in the provision of care for our patients, not to mention the ability to do effective training of the next generation. And what is correlated with that burnout, one of the top items that's cited in all the surveys and the literature, as you all know, is that loss of a sense of control and autonomy. Many factors leading to that. Other challenges include things like documentation, bureaucracy, the work hours, perceived appreciation, stress, and so on. And so what we've been trying to do at the University of Utah, led in large part by several of the members here, is to try to create a resiliency center, to build a resiliency center, which we have built and hired leadership and staff, and to try to create a hub to coordinate everything that we're doing across the entire health system and across the entire health sciences. And there are 3 programmatic pillars to that, which I have one slide on each of these, thanks to the team. Faculty and staff wellness initiatives, communication skills, and peer-to-peer counseling, in addition to setting up a satellite employee assistance program. So I have one slide on each of these. So the first is in terms of faculty and staff wellness initiatives. This is very, very important to us in order to think about the fact that wellness means different things for different groups. And so our wellness team has gone around. We have a chief wellness officer, Robin Marcus, who is a physical therapist from our College of Health. And she has partnered with Amy Locke from General Internal Medicine, with Rachel Hess also, to go around and speak with each of the leaders across our health system. What the orthopedic surgeons need is very different from what the pediatricians need and what the psychiatrists need. We're very committed to, not surprisingly given the leaders involved, tracking outcomes and metrics and sharing those best wellness practices across the entire health system and disseminating that knowledge across the country if we can. The second component, or the second pillar, is really around communications. We have another hospitalist, Nate Warner, who is completely committed to communication, so another general internal medicine physician, and focusing on training programs across our health system, modeling after our certificate on palliative education, which has a lot of didactic sessions and simulations, and it's been very strongly supported across our entire health system. The third very, very important observation that our team has made, which is that most physicians haven't necessarily felt comfortable reaching out to, say, social workers or psychologists. They're really more comfortable in a peer-to-peer kind of communication level. The surgeons want to talk to another surgeon when something goes wrong. That's really the level of comfort. So trying to build a strong peer-to-peer support program, especially immediately after unfortunate events that might happen, in order to facilitate recovery. And so I think that's another component, very important pillar. And then finally, we've built some satellite employee assistance programs. I'm sure most institutions have these kind of programs, but to try to get them dispersed across the institution so that our wellness initiatives can be viewed at multiple levels, at the individual level, trying to focus on self-care, communication skills, peer-to-peer with the satellite program, as well as offering executive coaching. At the department and provider practice level, a lot of focus on engagement of our providers in all of these initiatives we're talking about to try to restore that sense of autonomy, to restore that sense of control over their lives. And it's nothing like doing these quality and cost projects and access projects that really restores that sense of engagement and autonomy. I'll talk a little bit more about how some of those are working in a moment. And then academically, this is a part of our overall system mission, and of course across our entire health system, quality, communication, those are all critical to us. So let me in just the last couple of minutes share with you how this level of engagement of our physicians and strengthening of resiliency across our physicians is really helping us to move forward from where we are today. Just kind of the last few slides are more forward-looking. And where we have, I think we're on this trajectory now, and these are some slides that Bob Pendleton, another one of our general internal medicine leaders and our chief medical quality officer, shared with me, that we're starting down here at the level of physician insight. So just first showing people data, they're starting to get insight about quality, about costs, and then some peer-to-peer interactions and broadening our cost category work to the clinical team, and then finally really trying to move to the space that we most desperately want to really be able to have an impact on, and that is population health. And the trajectory of this is multi-pronged, I guess. So first, there's just simply giving physicians the information and empowering individual doctors. So here are some examples of some of the video we call value-driven outcomes. That's our measurement tool. The scorecards that we've been putting together with the physicians helping to guide us as to what we should be measuring and how we should be measuring it. So here's an example with Fred Welt, who is one of our interventional cardiologists who joined us from the Brigham a few years ago. And he was very interested in a particular intervention around, as you know, in pharmacy right now, there's a lot of erratic pricing of various antiarrhythmic agents, a number of different agents, and he did a project just in one particular drug, just from having his eyes opened at looking at his own scorecard, that led to a reduction in cost by $100 per dose of that particular drug. The peer-to-peer comparison, the idea of outmastering others, particularly resonates among the surgeons. You can interpret that as you will. This is Rob Glasgow. He's fantastic. He is one of our vice chairs of surgery. And he and Sam Finlayson, the chair of surgery, once they saw this tool, they became very interested in looking at the supply costs in the operating room, which are a big driver of costs. And you know how the nurses tend to prepare these big trays with all kinds of clamps and all these things that they never touch. And so they created a sub-tool of VDO called ORCA, Operating Room Cost Accounting. And that shows the surgeons their various supply costs in the operating room for every operation. You can actually see which of those supplies have been used or have never touched in the last decade, what possible alternatives there might be, lower cost alternatives. And I just tell you a very brief anecdote. One day Sam runs up to me in the hall, shows me his iPad. I think it was laparoscopic hernias or something that he does, and he says, oh, look, this is where I am. Quality, everybody was good. Cost, he was the second lowest. So I said, not bad, Sam, not bad being second. Rob was number one. So he comes back to me the next day and says, I have a plan. There's this dilator thing. Everybody tells me I don't really need it. I trained on it. Rob never uses it. When I cut that, I'm the lowest. I was like, great, Sam, that's wonderful. This is another one of our surgeons with his team, Charlie Saltzman. He's the chair of orthopedic surgery. And one of the areas, when you have a physician group engaged in the discussion about what does value mean, a resounding theme that comes up is these quality metrics that are getting imposed on us, like is the Foley catheter out within 48 hours, did we administer antibiotics, prior to incision, et cetera. Those don't really reflect true value or true outcomes measures. And so Charlie, as the chair of orthopedic surgery, is actually our institutional champion on patient-reported outcomes, believe it or not. So what he has done, and this is a picture of him with one of his iPads about 2.5 years ago, I'm going to say, he actually, on his own, bought iPads for all the clinics, used the Northwestern Promise system, NIH-funded program, kind of a computer adaptive questionnaire that looks at physical function, psychological well-being, and social well-being questions. It's every patient in the waiting room in orthopedic surgery for the last 2 years now has received this iPad, has been asked to answer these questions. They've moved it into, you can do it on your phone or you can do it at home actually before you come now. They've created the app. And so now that data, we actually broke the barrier, Epic barrier, so we can actually even see it in Epic. And that's our goal now for the entire system, to start recording patient-reported outcomes for every patient in our system. I think we're about halfway there. I'm looking at Rachel's nodding, halfway there now. So we're adapting some other quality of life metrics, other quality of life questionnaires depending on the patient population. And that's where we really think value should be going. We should be measuring value in terms of what CMS thinks is quality, what we might think is quality as physicians, some additional measures that are evidence-based, and then of course there has to be a patient voice there. There has to be an element of whether the patients derived value of that. And we've been working on system redesign across the entire entity, and I have just three, I don't even know if I have time. I'll just briefly highlight 3 examples of some of the top 50 projects that we're doing around driving value. This is Jeff Campson. He is one of our kidney transplant team physicians. He's now gone through 6 cycles of improvement that have gone from laboratory test utilization, medication management, ICU stays, every component of our transplant population. We are one of the top performing transplant programs in the nation, and through this engagement, he's a physician leader, we've saved $3.8 million. Kelsey Graves and Devin Horton, again, 2 hospitalists, 2 general internal medicine physicians, undertook early warning sepsis program, really integrated it in our EMR, trained up over 1,000 providers to be able to detect early warning signs of sepsis, saving lives, saving a lot of money. They're young, they are super engaged, they feel very empowered in doing this. They're fantastic. That's Chris Pelt, orthopedic surgery. He's done multiple iterations around our total joint replacement projects, and including leading our bundled effort, and he's like a tire-kicking orthopedic surgeon. But these are areas that are very, very important to each of their careers and very satisfying, and what they do with the savings, I should just mention something about that. It doesn't go to compensation, but what we use the savings for depends on what the physicians want. Some of them want a little more time to be able to publish and go and speak about this work. This is becoming their careers. Some of them wanted some of that money to come back to their divisions to hire more MAs and scribes to try to make their lives better. And some of them have actually moved into chief value officer roles just to take this on a broader scale. And when we have physician leaders like that, and when we have a culture like that, we're able to do things that are just much more patient-centered. So while we're all driving towards a patient-centered culture, I would say that we can't be a patient-centered culture until we've actually engaged our physicians. So here are 3 initiatives that were just rolled out last year in just one of our clinics that I'm very proud of as very patient-centered. The first one is on-site childcare. We provide on-site childcare for patients. Have a few kids in tow, you can drop them off at the child care center while you're being seen. Okay, you can't leave them for more than 4 hours. You're not allowed to leave the premises, even though there's a shopping mall across the street. The second one is in-home newborn visits. So how many of you can relate to this? Day 7, day 14, you have to bring your baby into the hospital, this tiny little thing. I'm in New York City, it's always snowing or raining, no taxi will stop for me. Finally get into the waiting room, and it's a waiting room full of kids with sneezing, running noses. So we now do baby visits at home. So a nurse and a pediatrician, they drive in their little Prius, they drive around the neighborhood and visit the moms and dads, the families at home. Great for keeping the babies well, but also for a lactation consultant, don't shake the baby, assessing the environment, and so on. And the third one is one-stop shopping for our patients, particularly around women. You get your pap smear, your mammogram, your melanoma screen, because we're in Utah. Get it all done in one morning. Everybody actually, all the doctors talk to each other, and then you get a report by the end of the morning. Very, very patient-centered initiatives, very much driven by a culture of very engaged physicians. And so with that, I want to say the future is very, very bright, and with all of you here particularly, you're the leaders in our institutions that are making this happen, and we are very, very grateful for your leadership, and just keep on pushing us. So thank you very, very much for your time. Some questions? Thank you. So it looks like I have about 4 minutes for questions. I'm told that I can take some questions. Maybe you need to use the microphone, though. Yeah, go ahead, please. No, go ahead, please.
Hi, I'm Laura Sessoms from the CMS Innovation Center, and it was a beautiful presentation, great work. I love your slides as always. Obviously there's a lot of value to be eked out of a system involving high-cost specialty care. What are your thoughts about value in the primary care setting?
That's actually an area that we need the most help from all of you. So the original tools and the original applications for us were, the most obvious were the inpatient, hospital-based, total joint replacement, cabbages, and so on. And we have built out now this tool, and those of you who have ideas, come over to the Utah table and let us know, share them with you, share them with us. We have built out the tools to enable primary care providers to look at cost and outcomes measures. And we're thinking about, there's already been a fair amount of engagement with our team in terms of starting to think about how best to define value, and we're engaging those primary care providers to help us think about it. I think we need more input and need more guidance about that. Clearly an opportunity, though. We'd like to be able to measure and reinforce the things that we think are the most important in primary care, whether it's prevention, counseling, mental health. One of the areas that we rolled out last year was a very strong partnership between primary care, all of our primary care clinics, community clinics, and our Department of Psychiatry, because one of the key messages that we kept hearing back is we need more access to mental health, behavioral health care. So we've made that investment. We now have the tools to measure, okay, what are the costs of care? What is it costing us now to care for this population? And is that worth the $1 million a year or whatever investment that we have to make just to provide that psychiatric access, even though we're not necessarily getting reimbursed for it? But we're looking forward to more input and thoughts from y'all. Tom?
I'm Tom Delbanco, Boston. Your charge today was to talk about doctors and resiliency and, and improvement, and you talked very little bit about patient experiences and patient involvement in getting what you're doing better. I have a sense running around the world that a lot of people are trying to put patients to work and working with doctors, with deans, with CEOs, with all kinds of big shots to improve the systems. They have user-centered design and all of that kind of thing. Can you talk about that a little bit?
Sure, absolutely. I think that observation just struck me when I took on this role, that unlike any other business, we really have very little engagement of our customers or our patients than any other area. And in fact, just the notion that we would share our patient reviews of us online publicly with people has been, I've heard a lot of controversy about that in the community. Like, oh, how can we possibly let that happen? When Yelp is getting into that, it seems pretty hard to deny that that's the direction of the future. We have a number of ways in which we are engaging our patients in, whether it's, we have in radiology a patient advocacy group that comes in and meets with the leaders and gives us feedback all the time. We have a number of different community groups that work with us very closely, whether it's around just generally in healthcare, patient focus groups, or patients who are on our various committees. We have a search committee for our CEO of the hospitals and clinics right now that we're searching for, where we have patients actually represented on that search committee. So we're doing our best. I think you have to find the right balance between individuals who may have their own perspectives, which are valuable but maybe limited, and these broader opportunities like in our patient satisfaction surveys, where we can allow tens and thousands of people to also express their view. And I think it's finding that balance that's going to be very helpful for us going forward. Thanks, Tom.
Hi, Bill Tierney from the Dell Medical School in Austin, Texas. I was a finalist for dean at my prior institution, and I realized going through that process that the dean doesn't really do anything. And running an organization, the dean actually sets the tone and the vision and the expectations and motivates other people and builds other leaders, etc. But who builds the deans? I mean, you obviously have had amazing impact, and it's admirable to see what you've done. I don't see that in all the deans that I've been interacting with, and so where does the leadership come from at that level, and how can we achieve excellence at that level, because I believe people throughout the organization want to be in the top 1%, and yet their leaders don't seem to be able to get them there. You have been able to. So how, where do those skills come from, and how do we build those in leadership at that level?
So I think you've asked a great question. I think that it's easy to point the finger to deans and say, oh, you haven't done what you could do. But I think that inherently in many academic systems, we have a structural governance problem that's very difficult for any dean to overcome. And what I mean by that is, if you look at all the academic medical systems in the country, and there's about 140 of us now, the number who have the organizational structure that we have, where the hospitals and clinics and the School of Medicine and the faculty practice all report to one individual, which happens to be my office, is very few. It's on the order of maybe 15 out of the 140. And so in many systems, and we have the additional benefit of colleges of nursing, pharmacy, health, dentistry, which in this day and age is incredibly helpful in thinking about the more interprofessional approaches to leadership in healthcare. But most systems are, the hospital reports up to some hospital CEO, sometimes it's even a private organization, then you have a dean over here every year going over and asking for some transfers, and it makes it very, very difficult for deans to lead. So I think, first of all, that structural problem is a real challenge in academic medicine. But your question is really more about leadership development for deans, and I really believe that the best possible thing an organization can do is to invest in its people and to invest in leadership development. The physicians are an incredibly, we are very good learners, right, as a group. And when you take the time to provide physicians with the skill set, even the kind of mini MBAs, I did go back and do a full MBA, but the mini MBAs are just a series of programs and to train up. Some of it is in the EQ kind of skill set and managing people, but some of it is just purely financial, strategic plan, operations, decision making, that kind of stuff. The more we can do that across the whole enterprise, it's not just for deans, it's for chairs, division chiefs. Look at all the people that I showed, none of them had administrative titles in those projects of VDO, and yet they are very effective leaders around sepsis, around kidney transplant, around orthopedic surgery. So we need that leadership training across the entire gamut.
Last question, please.
Thanks. David Atkins, Office of Research and Development at the VA, and thank you. We have a great VA collaboration with the University of Utah out in Salt Lake. It's a great center. So we're a research funder. You have a lot of health services researchers here. A lot of what you described is what is often called sort of little r research, rapid and improvement oriented. What are some questions that you would say we should be focusing on in the big R research realm? What are the things that you don't know that might take, longer 2-year, 3-year projects that would help you in your improvement work?
In 30 seconds or less? When I look across the landscape, and remember the book that I've authored is called Cardiovascular MRI. So that tells you how much I know about health services research. When I look across the landscape and I look at what has happened at the University of Utah, and I just want to be very clear, I inherited this incredible organization. I was very, very fortunate. We've been able to add more talent, but most of the momentum was already going even before I got there, so I don't want to take the credit for it. What I see is a tremendous need to create more networks and consortia across institutions. Because right now I feel like we are, as you described it, little r, we're trying to do things within our own system. We're learning along the way. We're learning things to do and not to do. And when we try to publish, it's difficult to publish because it's a single site study, and every academic medical center is different, and so it's hard to pull organizations together, and so it's harder to have that national impact. So given that all of you are coming from institutions across the country and from the VA and from CMI and so on, I think it would be fantastic if as a group you could come up with 2 or 3 priorities and then really commit to working together. Maybe, EHRs are a challenge, so maybe people who are on one set of EHR have to work together more and the others have to work on different ones, but to link arms and come up with 2 or 3 main priority areas. For us personally, I'm very interested in the measurement of value. I think providing that value data, the quality, patient satisfaction, cost data back to each provider, and then rewarding them, rewarding the divisions, not through personal compensation, but through other means, rewarding them for achieving high value is very important. I think really focusing on how do we really think about population health, how do we really do behavior change for our patients. We have so much high tech, but if we could just get them to take the pills, the blood pressure pills, I mean, that would be transformative. So that behavioral health component, that's something that we could all share, or behavioral change, I guess is what I mean, not behavioral health. And then how do we really work together with payers to create models that are going to be sustainable for us and reward the kind of work that we're doing now. So value, really engaging patients in behavior change, and then a payer-provider interaction models of payment that are going to actually work. I think those to me are the most important. Okay. Thank you. Thanks very much. Really good.